Thank you.
Thanks very much, Mir-Helen, for the nice invitation and for that very appreciative introduction. So I'm glad to be here, and I have put together a talk today to review some of the issues around cardiovascular disease epidemiology in rheumatic diseases. And I'm going to focus on some of the methodologic issues because I know that this is a group of internal medicine researchers and not necessarily rheumatologists or clinical rheumatologists. So we'll try to focus on the methodology, but if there's aspects of my talk that are confusing or you want me to highlight further issues, by all means, feel free to interrupt. And sometimes it's hard to see people, so Mir-Helen or others just speak up and I'll be quiet and I'll be happy to answer questions. Okay. So again, I'm the Chief of Clinical Sciences in Rheumatology and do a lot of work on clinical epidemiology outside of rheumatology, and also edit Arthritis and Rheumatology, the major journal in the United States on rheumatology. These are my disclosures. You know, I think about cardiovascular disease and RA as a real chicken and egg issue, meaning, you know, does the RA come first? Does the cardiovascular disease come first? Is it about the treatments that we, you know, is it a simple straight line arrow, or is it more complicated? And I think many of us who study the relationship between RA and heart disease think about the very relevant role of medications, as well as the possibility of common etiologies between RA and cardiovascular disease, whether those are genetic etiologies or other, and how one considers those when designing epidemiologic studies as well as clinical trials is really very important. So I'm going to talk a little bit about you know, the general area of cardiovascular disease in RA, and you know, what are some of the epidemiologic underpinnings, and then how we might think about bringing those epidemiologic observations to the bedside in the form of risk stratification. And then we can talk a little bit more about specific treatments and how management decisions might be informed by some of the epidemiology. And I always like to say that this is a real classic example of translational research. And I think that a lot of people like to focus on basic science when they think about translational. How does someone go from the basic science bench to the bedside? But I think that as epidemiologists and clinical researchers, we have the same set of challenges about how to take our observations that we might make in large data sets to the individual patient. And so we'll kind of think about that as we talk today. So you know, this is just a way of framing the discussion. Again, I don't want to make immunologists out of you today. We're not going to do that. But you know, the immunologic underpinnings of atherosclerosis seen here on the left the abdominal aorta, share similarities to the inflammatory underpinnings that we see in rheumatology clinic when we see a patient with swelling in the metacarpal phalangeal joints or subluxations and rheumatoid nodules. And this is a slide that I borrow from one of my cardiology colleagues, Paul Ridker. He talks about this when he does a lecture in pathology for the Harvard medical students. And Paul is really, as many of you probably know, he's really studied the inflammatory underpinnings of atherosclerosis for 2 decades. This is a paper from 2000 that looked at the relationship of IL-6, an important cytokine, and the relative risk of myocardial infarction. And you can see that across the quartiles of IL-6, that there's an increasing risk of myocardial infarction. He went on to look at this using a much more commonly measured biomarker, high sensitivity CRP, and its relationship to MI and its relationship to stroke. This is using a case control methodology from physicians that are involved in the Physicians' Health Study. Again, a very similar increasing risk for cardiovascular outcomes across quartiles of hsCRP as we saw with IL-6. And this is not just a phenomenon that we see here at Brigham and Women's Hospital, but it's a, this has been seen across many, many studies. And here I'm just showing you data from a meta-analysis of 54 prospective cohort studies, and that there's this very nice dose gradient across elevations in hsCRP and the risk ratio for, on the left, coronary heart disease, and on the right, all vascular deaths. So this is an important phenomenon, and it's not just of epidemiologic interest, but when we think about how it might relate to clinical care, hsCRP per standard deviation increase is associated with a 37% increased risk of cardiovascular endpoints, similar to systolic blood pressure, even more important than total cholesterol, and similar to LDL or non-HDL cholesterol. So hsCRP is not just a phenomenon that is only a laboratory phenomenon, but it's an important way of risk stratifying patients that people have gone on to use in risk stratification tools like the Reynolds risk score, which Paul Ridker and some other colleagues developed. I'm not going to talk about that, but it's more than just an epidemiologic observation. But there's also a basic science underpinning, and this is from a Nature, a review in Nature from a decade ago. My colleague Peter Libby, who was chief of cardiology for 2 decades here at the Brigham, has studied the immunology of atherosclerosis, and he finds important increases in T cell populations as well as B cell populations, antibody production, as well as interferon production. So there's a lot that goes on around this lipid core, which forms the central pathology of atherosclerosis that has an immunologic underpinning. But this is from a decade ago, and I'm going to show you in a little bit kind of an updated slide. But there's, as epidemiologists, we don't want to just be studying things that we observe in data sets. We want to make sure that they have a biologic basis. And so I always, when I look at an association, I always say, does this make any sense, or is this just a statistical phenomenon where you have large numbers of people and you've compared lots of potential predictors with potential outcomes? Of course you're going to find something that's statistically significant, but does it have any clinical basis? And I think that having a biology that underpins what we observe in epidemiologic studies is incredibly important. How do we prove causality? There's Austin Bradford Hill was an epidemiologist in the 1950s 40s and 50s and 60s, and he proposed Hill's criteria, which are very important when we think about the potential relationship of associations to causation. And Hill, Austin Bradford Hill, thought that the strength of the association, having a dose gradient effect, and the consistency across studies was all important. But I also think that we want to think about how we can test associations in randomized trials. And I think you'll see, and I think you're all familiar with it, this inflammatory hypothesis, while it was observed in epidemiologic studies that seemed to fulfill many of Hill's criteria, it's now also been studied in randomized trials. And Jupiter was the first attempt at this. This is from a decade ago. Jupiter looked at rosuvastatin or Crestor at 20 milligrams a day compared to placebo in about 18,000 patients. These were all patients that had normal LDLs, they had elevated hsCRP, and they had no known coronary artery disease. And there was a 44% reduction in the incidence of cardiovascular events. This gave us a number needed to treat over 5 years of 25. So very clinically relevant effect. But what we don't know based on the Jupiter trial was whether this was because of this reduction in hsCRP or whether it was a reduction in the LDL, because we know that a statin is able to achieve both of these. And there was a 50% reduction in LDL in Jupiter, 37% reduction in hsCRP. And so Jupiter was not able to really tease apart these two effects of rosuvastatin or other statins, but it gave us a strong suggestion that perhaps this, reduction in inflammation might be associated with or causal of a reduction in CVD. And if we skip forward 10 years, there's data that were generated also by Paul Ridker and others at the Brigham in the CANTOS trial. And CANTOS was a double-blind randomized trial with 10,000 patients, all had known CAD with a prior MI, and they all had hsCRPs above 2 milligrams per liter. They were given canakinumab, which is a very interesting agent which blocks IL-1 beta. And we know from the biology that IL-1 beta is important in the development of athero, and IL-1 beta goes up at the time of a myocardial infarction. And so it's thought to be important. And so that, again, there's this biologic basis for testing out a specific intervention. As well, canakinumab does not affect LDL, it does not affect blood pressure, and it doesn't have a major impact on glycemic control. And so it was felt to be a really good way of testing this inflammatory hypothesis. And so in the CANTOS trial, 3 different dosages of canakinumab were given every 3 months compared to placebo. The outcome was MI, non-fatal stroke, or CV death. And it was observed that hsCRP dropped by 30 to 40%. And I think the rest is kind of history. People are aware that there was a 15% reduction in cardiovascular endpoints, primary or the secondary endpoints with canakinumab 300 milligrams or 150 milligrams. So this was, again, kind of the proof of concept that a anti-inflammatory or immunomodulator could reduce the risk of cardiovascular endpoints. So again, you go from an epidemiologic observation that I showed you 10 slides ago, where across gradients of hsCRP, there's an increased risk of cardiovascular endpoints. You go to Jupiter, where you see some more suggestion of this, and then you look here in CANTOS, and there's strong evidence that this inflammatory basis of athero is proven in the setting of a trial. So, the immunology gets rewritten as we learn more. And so, this is a cartoon from a review article in 2018, and it kind of, again, further elaborates the immunologic basis of cardiovascular disease. and how cholesterol crystals prime the inflammasome through this, being they're a damage associated mediator through this PRR receptor. The NF-kappa B gets turned on, NLRP3 and IL-1 beta start to be produced. And then there's a second signal, and the inflammasome is now assembled through some of these signals. So it's this kind of two-signal hypothesis of inflammasome assembly, and eventually IL-1 beta is produced and released through pyroptosis. And this is believed to be an important mechanism of atherosclerosis, and the rheumatologists in the audience will know that this is also important in gout, and it may be that these are some of the shared mechanisms between gout and cardiovascular disease that might cause such a strong association between those two conditions. Again, whether it's causal or shared mechanism is still something that we're working on, but you rewrite the immunology as you study, you do clinical studies. So again, we know colchicine blocks this transcription of NLRP3 and IL-1 beta. We know that canakinumab blocks IL-1 beta once it's released. And we know that these drugs both work on cardiovascular disease. And here is data from the COLCOT trial, a colchicine trial, a double-blind randomized trial, looking at the effect of colchicine to reduce the risk of cardiovascular endpoints in patients who are within 30 days of an MI. And you can see here there's a 23% reduction in the primary composite endpoint. So again, we learn from epidemiology, we learn from basic biology, and it culminates usually in a randomized trial, which is really the way that we often prove some of our epidemiologically generated hypotheses. This has been tested in another trial published in the last couple of months, LODOCO-2, another double-blind randomized trial. There was a 30% reduction in cardiovascular risk. Now we're looking at patients with chronic CAD, not just patients with recent MI. So again, just another important piece of data in this puzzle. These are some of the components of the composite endpoint. I'm not going to go into those today. So again, we started out by talking about RA, and I've just shown you data from the general population, which I think is incredibly important when we think about cardiovascular disease in patients with RA. Is there something we can learn from our rheumatoid population about cardiovascular disease in the general population? We know, the rheumatologists in the audience know that RA is a disease of systemic inflammation. The inflammation, inflammation is not just one thing. Inflammation has lots of different parts to it, lots of different pathways. RA, lupus, scleroderma, ankylosing spondylitis, psoriatic arthritis, these are all different immunologic diseases, different treatments, different pathways. But are there similarities in the inflammatory pathways underpinning athero that might be informed by understanding cardiovascular disease in RA? And so let's turn our attention now to some of the epidemiology underpinning cardiovascular disease in RA. This is a study that we did 20 years ago using data from the Nurses Health Study, where we looked at patients with RA, patients without RA, and we looked at MI, and we looked at stroke, and we did a very large prospective study of the incident rates of MI and stroke in these two populations. We calculated incidence rates, we did age-adjusted relative risks, and then we calculated multivariable relative risks in Cox proportional hazards models. And you can see there's a doubling of the risk of MI in rheumatoids compared to non-rheumatoids after controlling for many, many important potential confounders. And we saw a 50% increased risk in stroke that was not statistically significant. based on a very small number of strokes that had been logged in this database at the time. We're updating these analyses now. So that was the Nurses' Health study. We then went on to look at a much larger database. This is administrative data that we were collaborating on with some Canadian researchers from British Columbia. We look at rheumatoid arthritis based on 3 diagnoses versus patients who have no diagnoses of RA. And I'm showing you, these are matched on age, gender, and calendar year. And this is an unadjusted set of analyses. So here we have 25,000 patients that fulfill this diagnostic criteria compared to 250,000 without. So it's a 10-to-1 match based on age, gender, and calendar year. And then when we look at how many cardiovascular events, 1,000 events in the rheumatoids and 6,000 events in the non-rheumatoids, giving us an incidence rate of 14 per 1,000 person years or 9 per 1,000 person years. So a 60% increased risk in the rate ratio, which is another way of just estimating the relative risk across rheumatoids and non-rheumatoids. And for this crowd that's interested in epidemiology, I'll just point out that the rate ratio, again, another estimate of the relative risk, is highest 3.3 in the patients that are 18 to 49, and it seems to diminish in the patients as they age. And we could discuss this for a while, but any one risk factor becomes less influential when there's many risk factors in a population. And as patients age, they develop diabetes and hypertension and hyperlipidemia, and they smoke and they become obese and they age, and therefore rheumatoid arthritis appears to be less important over the decades. But you'll see that the rate difference between rheumatoids and non-rheumatoids goes from 1.2 to 20. So the rate difference keeps growing, but the rate ratio for rheumatoid arthritis diminishes. Again, I think if you think about that, it's this difference between absolute risk and relative risk. And it's an important observation for epidemiologists to understand. It's not something that most clinicians completely get, but I think this audience will understand it. Here's a meta-analysis. So after you study something for a couple of years, someone decides that they should write a paper and do a meta-analysis. And sometimes this is useful, and sometimes it just proves what we already know. I would put this paper in the category of it proves what we already know, and it shows that there's a 50% increased risk of cardiovascular outcomes in rheumatoids. It's not bad to show it, but I don't know if we learned something new from this kind of a meta-analysis. So how do we take this epidemiologic data and, again, take it to the bedside? How do we think about a given patient when we have these epidemiologic observations? And I would argue that one of the ways is to risk stratify. How do we look at a given patient in a clinic and think about their risk of a given outcome, heart disease in this example, but it could be something else, and does the epidemiology inform this? And so we were interested in trying to develop a risk stratification tool, and so we went to data a decade ago from a registry called Corona. At the time, they had 10,000 rheumatoids. Now they have 35,000 rheumatoids. And at the time, the median observation was about 2 years. Now it's longer. And we looked at traditional cardiovascular risk factors listed here, or RA-related variables listed here, duration of disease, serologic status, clinical disease activity index, the presence of rheumatoid nodules or erosions, total joint replacements. The health assessment questionnaire is a functional status measure, and we didn't have CRP on these patients. We looked at, there were 76 cardiovascular events, giving us an incidence rate of 4 per 1,000 person years. And what we did is looked at how different types of risk factors, cardiovascular risk factors on the z-axis, and RA factors on the x-axis, how they contributed to the incidence rate of cardiovascular events. And what you see is that cardiovascular risk factors were important, but so were RA factors, and the people with the highest risk were these people in the back corner. And that's kind of proven by the area under the receiver operating characteristic curve, or the C statistic of a logistic model, 0.57 when you only have CV risk factors. It goes to 6.1 when you add in age and gender, and then it goes up to 0.71 when you add in these RA factors. So this is a way of statistically showing the importance of RA specific factors. And we've shown this now in another way of thinking about this, and Mirhelen and other rheumatologists know that we think a lot about treating to a target disease activity in RA, and that's a paradigm that we think is important for reducing pain, improving function, and reducing disability over time. And we were wondering whether that might be associated also with reductions in cardiovascular risk. And so what we looked at was Cox models, where we looked at patients who had a high disease activity over time. And these are time averaged clinical disease activity measures, looked at longitudinally every 6 months. And then we looked at the hazard ratio for patients that were in moderate, low, or remission, and whether we did a variety of models, but you always see that people in remission or low have a much lower risk of cardiovascular outcomes than patients that are in moderate or high. So again, it's trying to take this epidemiologic understanding to the bedside and giving rheumatologists another rationale for why treating to target disease activity might be important. And another way of looking at this is using a biomarker score. And here we're using the multi-biomarker disease activity assessment score, or the VECTRA score, which is just one 12 analyte score that we can order. It costs like $1,000 in the United States, so it's not ordered much clinically, but there are some research studies that use it. And you can see that across quartiles of MBDA, there's an increasing risk of MI and of any CHD. This multi-biomarker disease activity score correlates very well with the CDAI, which I showed you in this figure. So these are very similar types of studies. This is a biomarker study. This is a disease activity measure study. There's been this kind of interesting paradox observed initially by Elena Maisidova at Mayo Clinic, asking the question of whether lipid levels are somehow have a different relationship to cardiovascular disease in patients with RA. Lipid and LDL is probably the best biomarker for predicting cardiovascular disease in the general population, as we know. But she made the observation that it seems like as you increase total cholesterol or LDL, the hazard ratio for CVD doesn't go up. And so this was kind of termed the lipid paradox. I think it's kind of a cute epidemiologic phenomenon. I'm not quite sure how relevant it is, and we've looked at it in patients that we have at the Brigham. We looked at it for LDL, looking at the odds ratio for major adverse cardiovascular events, or MACE, and we see this downward slope that they saw in the Mayo data, as I show you here, but we see that it starts to go up with higher LDLs. For HDL, as you anticipate, it goes down, but then it seems to stay stable. And what I asked Kat to do was to look at it in non-rheumatoids as well as the rheumatoids, and you could see that there's a very similar set of curves in non-rheumatoids and rheumatoids. So again, I'm not sure if this is a specific phenomenon in rheumatoids, and I don't know that we really completely understand this paradox. I do think that having patients who have systemic inflammation probably means that the meaning of LDL is slightly different. And I'll talk about that in a few minutes when we talk about some of the drugs that we use in RA, which also impact LDL. But it may be the case that, going to the bedside with risk stratification tools like the Framingham risk score may not work as well in rheumatoids. And these are data generated from the Mayo Clinic's population of over 500 patients with RA. They looked at a data set with 84 incident cardiovascular events. And what they're showing here is that the observed cardiovascular event rates are in black, are higher than the predicted in white based on the Framingham risk score. You could see the deciles of predicted risk, and there's this discrepancy shown by this red bar. And so they were one of the first groups to say maybe the Framingham risk score underestimates risk in rheumatoids. And I think that's an interesting point. And a couple of years later, we went and tried to build a better risk score. And here we're using data from Corona. And this is a population, I think we had 25,000 rheumatoids in Corona when we built this model. And we added in several RA risk factors. We looked at many risk factors. The 4 that were important were the clinical disease activity index, a CDAI, the functional status score, the MHAC, the use of any prednisone versus none, and disease duration of 10 years or greater. And when we add those 4 variables in, we improve the ability to predict cardiovascular outcomes. You can see that the area under the receiver operating characteristic curve improves. So the model with these 4 variables, we're calling this blue line, and the base model is red. And you can see that the area improves by a little bit. This is statistically significant. And when we go and actually look at the prediction using this expanded risk score, which includes the RA variables, what I'm showing you here is that we improve the ability to correctly classify patients' risk. And that's shown here as the net reclassification index, the NRI, is quite high, 40%. 17% more RA patients would have their CV risk correctly classified when we use this expanded risk score, which includes these RA factors. And I'm showing you, the green arrows show you these risk categories where we improve risk prediction using an expanded risk score. There's one group where it actually gets worse, and that's to be expected. It's not going to improve every prediction in every risk category. And this has been externally validated now in several Swedish cohorts. We worked with our colleagues there, and this is a paper published last year where we show that the expanded risk score is valid using external data. So it's not as if this risk score has been widely taken up. We've tried to give people tools, and you can go to our website and you can play with a tool that allows you to take a given patient and estimate their risk using this, what we call the ERS-RA, which is kind of our modified Framingham risk score for patients with RA. And this is a way, again, of us thinking about how to go from epidemiologic models to the bedside. So giving patients information, giving clinicians information that we think is useful. So let's think about how we might use some of the epidemiologic data and other data to consider an evidence-based approach for treatments. And this is a patient that I often talk about, a middle-aged woman with cardiovascular disease who she has cardiovascular risk factors, but no known cardiovascular disease. And rheumatologists, we think about which treatments we might give her for her RA based on knowing that she has CVD risk factors, and should her CV risk profile influence this. And we can talk about some of our treatments: methotrexate, biologics, steroids, and non-steroidals. And these are data from some observational studies of methotrexate. And this is a meta-analysis that I was involved with, looking at over a dozen different observational studies where we found about a 20% reduction in the risk of cardiovascular outcomes in observational studies in patients with rheumatic diseases, RA, polyarthritis, or psoriasis. And these were some of the data that were important in thinking about the structure of the CERT trial. And I think this group is probably aware the CERT trial was published in the last year in the New England Journal. Again, this is a trial that was led by my colleague Paul Ridker here at the Brigham. I had the honor of working with him. I kind of tried to keep these patients safe on methotrexate. It was a trial that was run out of cardiology. Patients received low-dose methotrexate, 15 to 20 milligrams per week. They all received folic acid in the placebo arm, and in the low-dose methotrexate, they all had known MI or known CAD. They had known diabetes or metabolic syndrome. These were the endpoints. And unfortunately, a trial that was stopped early due to futility because there was no separation of the curves. And there really wasn't a significant reduction in IL-1 beta, interleukin-6, or C-reactive protein. And you can see here the cumulative incidence curves for placebo and low-dose methotrexate were not different. And rheumatologists always ask me, like, why didn't this work? Why was it a failed trial? And they usually say, well, it's because the patients didn't have high enough CRPs. And it's true that patients didn't have high enough CRPs, and that's one of the possible reasons. It's possible also that just methotrexate actually doesn't reduce the risk of cardiovascular disease in a trial, that it's possible that the observational data are all confounded. It's also possible that methotrexate reduces the risk of cardiovascular disease in patients with RA or other rheumatic diseases, but not general population patients. So I think that randomized trials answer a very specific question, and sometimes that doesn't generalize to everybody. And so that's an important lesson from the CERT trial. But we've been very interested in whether other treatments for RA might be important for cardiovascular disease. And these are data from an observational study published a decade ago in Circulation. These were all patients with RA. All the patients had active RA. They were compared to patients with no RA that had known cardiovascular disease. And FDG PET scans were done, which is an intermediate endpoint which looks at vascular inflammation and is moderately well correlated with cardiovascular outcomes like a heart attack and stroke. And this is looking at the aortic TBR, total to background ratio, and the total to background ratio in the most disease segment. These are two commonly used metrics. And what you can see here is that the administration of a TNF blocker, in this study it was Enbrel or Humira, was associated with a significant reduction in both of these measurements. And the measurement was similar to what cardiovascular disease patients had. So this was a very interesting study that we looked at. And there's other data, observational data, that we've contributed to, a co-author on a number of these studies that suggest about a 30% reduction in cardiovascular outcomes across many observational studies in patients with RA. So again, giving good suggestion that TNF blockade might be associated with a reduction in cardiovascular disease. And so we've designed a trial, as Mir Helen noted, I'm the co-PI on this NIH trial with my colleague Joan Bathon, and we've just actually finished enrollment, and we're now involved in the 6 months of follow-up for our last patients. So 150 patients randomized to either methotrexate plus a TNF antagonist or methotrexate plus sulfasalazine and Plaquenil, otherwise known as triple therapy. These were all patients that had high disease activity, methotrexate inadequate responders with a disease activity score above 3.2, puts them in the moderate disease activity. At baseline, we did a FDG PET-CT, and then 24 weeks later, we did a PET-CT. And so what we're looking at, similar to what I showed you in that observational study, is the change in the total to background ratio as measured by the, at the most disease segment on the PET-CT. And we have some nuclear cardiologists who are very expert at reading these PET-CTs. They're the central core reading lab, and they're reading all the PET-CTs. We have 30 centers across the country in the US, all contributing patients. And again, we enrolled 150 patients as of last week, and we're now in the 6 months of follow-up for the last 25 patients, and then we'll unblind and look at the data. But other agents like Tocilizumab, an IL-6 blocker, tofacitinib, a JAK inhibitor, are associated with increases in LDL and total cholesterol. So that's pretty interesting. And I've been involved in a very large observational study that Genentech, the makers of Tocilizumab, funded. And we looked at 3 different databases using observational methods, including propensity score matching. And we matched patients on Tocilizumab, 9,000 patients on Tocilizumab with 18,000 patients on a TNF blocker. And we looked at the number of cardiovascular events, the incidence rates, and the hazard ratio shown here. And you can see the hazard ratio really was, if anything, slightly reduced in Tocilizumab versus TNF blocker, even though Tocilizumab, an IL-6 blocker, raises LDL. And this is what I talked about before, that it's possible that inflammation in IL-6 has an interaction with LDL. And it may be that even though there's elevations in LDL, that these elevations are not associated with increases in cardiovascular disease compared to TNF blockade here in this observational data. And this is called the INTRACT trial, published in the last year in Arthritis and Rheumatology. And this was a randomized trial, and the hazard ratio, again, was 1.05, comparing etanercept, a TNF blocker, to Tocilizumab, an IL-6 blocker. So again, the observational data shown up here and the randomized trial data shown here were very complementary and really with no difference. So that's really, I think, an interesting, important observation as epidemiologists, that a well-designed observational comparative safety trial can contribute important information. Steroids have only been studied in observational data because we don't do large randomized trials of steroids at this point. And as Mir-Helen knows, that steroids and disease activity in RA are almost synonymous, meaning there's very strong confounding by indication. People take steroids when their disease activity is high. And so my first mentor, Matt Liang, said to me 20 years ago that trying to disentangle the effects of steroids from disease activity is like trying to unscramble an egg. And I believe that. Having said that, I also believe that steroids are probably associated with an increased risk of cardiovascular disease. And so clinically, I'm always trying to reduce steroid doses. NSAIDs and COXIBs are, we know, associated with cardiovascular outcomes and are contraindicated in patients with recent strokes or heart attacks. And these are data that we generated from the Precision trial, a very large, the largest NSAID trial to date, 24,000 patients, where we compared traditional NSAIDs to COX-2, celecoxib, and we found similar risk of cardiovascular endpoints in OA and in RA. If anything, celecoxib might be safer than ibuprofen, but this was designed as a non-inferiority study. These data actually are very similar to many years of data we generated in observational data. And so it was very heartening to see that a very large randomized trial basically replicated what we had been saying for years based on observational data. So again, observational and randomized trial data complement. This is from a review article from the BMJ that just kind of talks about why studying RA and heart disease is kind of fun, but complicated because there's really many, many factors associated with heart disease and its potential relationship to RA. And so as an epidemiologist, we have to take into account all of these variables, which is tricky and difficult based on data sets. I put this in for people who are interested in therapeutics because what's happening now is the cardiologists are stealing our treatments from rheumatology and bringing them into cardiology. And so all of these different drugs, including methotrexate, are in various trials for heart disease, which is, really interesting in my mind. So conclusions: inflammation predicts athero, but still unclear if treating inflammation in RA reduces CVD. It likely does based on the observational data. Patients with RA are at increased risk of all forms of CVD, including DVT and PE, as well as heart failure. I didn't show you those data, but there's good data, consistent data about that. Traditional CV risk factors tell part of the story between RA and CVD, but systemic inflammation also underpins this risk. And I think that's why I've been able to get my work funded, because I can always say I'm not just studying RA, but I'm studying a more generalized phenomenon of systemic inflammation. And lowering RA disease activity likely reduces CVD risk. But it's possible that different treatments may differentially impact risk. And that's really why we were funded to do the target trial, which is going to study triple therapy versus a TNF blocker. So there's a lot of clinical implications that I don't know if they're as important for this audience, but Merhelen, this will ring true to you, Merhelen. So why don't I stop there? I've kind of talked a lot about a lot of topics, and I'm happy to take questions.
Yes.
I just put you guys on gallery, so
yeah.
Should I stop sharing?
Yeah. So thank you so much for your nice presentation. It was really what I asked you to present for us. There are several students here, and they are getting familiar with methodology and how to develop epidemiology studies and how epidemiology studies can improve our comprehension regarding to etiophysiology, pathogenesis in rheumatic disease, inflammation. There are some patients, some questions here. I will open for questions.
Yeah, sure.
While people are presenting, I would like to emphasize your work on comparing methotrexate and recently published at New England, and we didn't find that methotrexate could, the use of methotrexate could, didn't change the inflammation and the inflammatory indicators. Oh, the sound is someone talking together with me. The sound is, can you hear me?
Yes.
Hmm. So I would like to explore more your recent study published at New England about methotrexate and its ability to, it was not proved that it decreased the cardiovascular events. Could you talk more about this study and how do you get patients and how it was the hypothesis constructed and so on about this study, please?
Sure. No, happy to. The cardiovascular inflammation reduction trial, the CERT trial, which Helen, you're referring to, was a large randomized trial with cardiovascular outcomes as the primary endpoint. And these were all patients that were not rheumatology patients. It was general cardiology patients with known heart disease. And it was a trial that was done based on the observational studies that in rheumatology that suggested that methotrexate was associated with a reduction in cardiovascular outcomes. But again, until you test it in a placebo-controlled trial, sometimes confounding bias can cloud the picture. And so we don't know if an association is a causal association or if it's just a, what I would describe as a casual association, not a true causal factor. And so, again, this was a very large scale randomized trial. 5,000 patients were enrolled across, over 100 sites across the US and Canada. It was a, very large scale NIH funded trial. I think it was a $70 million trial. It wasn't, it was a very large trial, which was run by cardiologists. And again, there was an outside data safety monitoring board that was monitoring all the events in both arms. And they were watching to see whether there was any division, whether there was separation between the incidence rate of cardiovascular events in low dose methotrexate versus the placebo. And those are the interim analyses that warranted stopping the trial early because of futility. There was no evidence of any difference in the rates. Again, we don't know that why there was similarity. We just know there was similarity. Again, some of the hypotheses are that people didn't have high enough CRPs. People, maybe the drug just doesn't work in general population patients, or maybe, it's only patients with rheumatoid inflammation that methotrexate might reduce cardiovascular disease, or it just doesn't work for cardiovascular disease. And I don't have the answer to that question. Whenever I give this talk to rheumatologists, they always like to say, well, we know it works on cardiovascular disease. It just must be that they didn't have patients with high enough inflammation. And I can't say they're wrong. They don't really know. We don't have evidence that they're correct. We just don't have evidence that they're wrong. And the absence of evidence makes it hard to prove anything.
Mm-hmm. Yes, exactly.
Can I ask a question?
Yes.
Yes.
First of all, congratulations, Dr. Solomon, for your excellent presentation, very inspiring. Now, my question goes back to your first slide on the egg and the chick. The question is, coming from the standpoint of the cardiovascular disease, we don't see very much patients with rheumatoid arthritis. Just if you come from this side of the conundrum, these patients are very inflamed, but they don't develop the articular diseases. Can you do some sort of
Sure.
reasoning about that?
Yeah, let me talk a little bit more about that. And thank you it's a good question. And I think that saying that cardiovascular disease causes RA is not true. That would be an overstatement. But I think that what rheumatologists are now struck with and I'll now go outside of cardiovascular disease, is COVID. And we see patients with systemic auto-inflammatory COVID, right? They have cytokine storm. They have elevations in IL-1 and IL-6 and IL-18 and all the factors that we see in the cytokine storm picture of a patient with systemic JIA, or having cytokine storm from CAR T therapy or other things, or COVID. And we see some of those patients now develop autoimmune disease. So there's lots of data in the literature now that patients post-COVID are developing what appears to be chronic autoimmune diseases. And so it's likely that when we think about the pathophysiology of RA or other autoimmune diseases, we always think that in the right genetic host, with the right environmental triggers, in the right situation, that patient might trigger an autoinflammatory setting that may then go to autoimmunity. And autoinflammation, as we know from COVID, can be triggered by infections, right? That's what we see in COVID. Starts out as a viral infection, and then a week later, all kinds of stuff is happening that is not just from the infection, it's from the body's reaction. It's autoinflammation due to the setting up of this cytokine storm. And I don't want to get into the immunology, but in the same way, some of these same pathways that we see important in systemic inflammation of RA are the same IL-1, IL-6 pathways that we see are important in cardiovascular disease and in gout. And so whether this is about causation or shared pathways is very unclear. And again, there's probably some shared genetics, and there's probably some shared, for decades, people have been talking about infection being a potential trigger for cardiovascular disease. So perhaps under the right situation, infection might trigger RA, and in other situations, it triggers CVD. I don't know. I'm just putting this out as interesting hypotheses. We think about the microbiome as being very important. The oral microbiome as being very important in RA. We know that, there's many different studies that show that different microbial pathogens and different distributions of the microbes in the oral and in the GI system are associated with RA. I don't know if they're causal, but they may be part of that environmental milieu that triggers autoinflammation that then becomes autoimmunity. That's kind of the current thinking, but it's a little vague, I'll admit.
There is another question.
Good. Hi.
Heitor.
Can I?
Yes.
Yes.
Dr. Solomon, thank you very much for your presentation. By the way, I'm Heitor, the one who sent you the invitation, and I have to thank you for accepting the invitation on behalf of the program, indicated by Dr. Mihaly, obviously. But my question is, as you mentioned, COVID-19, so I was wondering if you have information on the outcome of your patients during this pandemic, because I work with inflammatory bowel disease, for example, in patients using immunosuppressants and biological agents, and they are surprisingly behaving very well with very mild disease related to COVID-19. So do you have information on that for rheumatic patients using immunosuppressants and biologicals?
I have some information. So as Mirhelen knows, there's been a global effort to enroll patients in some registries. And so we have some information using data from 5,000 or 10,000 patients, looking at the incidence of COVID based on disease and based on different immunosuppressives. but I would not say this is perfect data at this point. This is just preliminary information. But we don't see that RA itself is a risk factor for COVID. But it does appear that people who are on higher dose steroids before COVID are at higher risk of developing COVID. But then we all know that dexamethasone, when given to people who are on mechanical ventilation or having, dips in oxygen, they might be helped by dexamethasone, a steroid, when they're developing kind of this auto-inflammatory component of COVID. So it's tricky. It's hard to say that, steroids are always bad or steroids are always good. They're probably different in different times during the illness. But there are good randomized trials of IL-6 blockers. IL-6 blockers, while there were case series suggesting that IL-6 blockade was good for people who were developing cytokine storm, in randomized trials of people who don't have rheumatic disease, who were given IL-6 blockers, it doesn't appear that IL-6 blockers help with the course of COVID. But your question is if people like with IBD or RA are on immunosuppressives before they get COVID, do they have a worse outcome? And we don't, other than steroids, higher dose steroids, we don't see that patients on immunomodulators like JAK inhibitors or TNF blockers or IL-6 inhibitors, we don't see worse outcomes yet. But again, we're still trying to do the observational studies that would give us that information. But I can tell you that the American College of Rheumatology convened a task force with immunologists and rheumatologists, and they suggested that patients should just stay on their immunosuppressives and not stop them before they get COVID. If they get COVID, we generally are telling patients to be cautious, maybe stop for a week. And then some patients, there's now trials of JAK inhibitors for patients who get COVID. So baricitinib, which is a kind of a second generation JAK inhibitor, is being tested in randomized trials to see if it might help non-rheumatic patients who develop COVID. And there's some promising evidence, but we're still too early it hasn't been really revealed. So the observational data can be tricky, as I'm saying, is that once we get to the randomized trials, we have a better understanding. So again, bottom line is we tell patients to stay on their drugs if they have rheumatic disease. And if they don't have rheumatic disease and they get COVID, we only know about remdesivir and we know about dexamethasone and we know about prone ventilation. But the rest of it, anakinra, IL-1 blockade, JAK inhibitors, are just in trials at this point. And we don't really know the answer.
Miriam Abreu.
Another question.
Sorry. Okay.
No,
okay, go ahead.
So is there any trial on targeting platelets? And is there or information on using anti-aggregating agents, anti-platelet agents
Yes.
could help preventing cardiovascular disease? Okay.
There's a large NHLBI. The NIH has funded a large trial. I actually think that Paul Ritker is running it on giving patients antiplatelet agents at different phases of COVID. Now, one of the problems with this is that it's almost become standard of care in the United States to give patients antiplatelet agents. And so differentiating from standard of care is very difficult. And I could tell you that I'm on the IRB at Harvard, and 3 months ago, there were some hematologists that wanted to do the trial, and we said it's impossible to do the trial because everybody's already getting antiplatelet agents at our hospitals. And so how do you measure the impact of, standard of care was changing. Everybody was getting different regimens versus a new, NOAC, a new novel oral anticoagulant. So it's been a very tricky area, but it's an important area.
Thank you.
Thank you. Miriam is asking if is it the same rationale for other infections like Zika virus? Miriam, could you develop better your question? You're mute.
Hi, everyone. I'm glad to be here. Thank you for the opportunity. I'd like to know if we can relate this rationale about COVID-19 with the other infections like Zika virus. Is there a relationship?
Yeah, it's a it's a question that everyone's asking. I believe that there is. I mean, Mir-Helen and I know that Zika virus causes autoimmune or autoinflammatory disease that looks like RA in some patients, and we know that some patients with Zika get very sick, and some patients get a very mild illness, similar to COVID. I'm not a virologist, so I can't tell you that I understand the immunology of Zika or Corona completely, but I think that there's a lot of similarities. And I think that one of the goods that will come out of coronavirus research is that we'll understand more about other viruses and how they provoke illnesses that are sometimes short-lived, sometimes severe, sometimes long-lived. And that's what my colleagues and I here at the Brigham are looking at, looking at patients who have COVID and then looking at them long-term to see if they develop autoinflammatory and autoimmune disease and what happens to their immunology, their T cells, their B cells, and their clinical phenotypes. So it's a great question, and everybody wants to know the answer. I don't think we have the answer, unfortunately.
Let me see if there are. We cannot forget about the pandemic COVID-19 and also the inflammatory. Mirellen, here.
Yeah, hi.
I'm asking.
Yeah, no, I see. Somebody else raised their hand. I see somebody else.
Yeah, I see, but I don't know who.
Mirellen. Roberto.
Okay. Roberto Gamaschi is a cardiologist, and he's studying cardiovascular outcomes in rheumatoid arthritis. Go ahead, Roberto.
Okay, thank you. Congratulations, Dr. Solomon. It's a great pleasure to know you. We are working with Dr. Mirellen as a postgraduate now. And we have read many articles written by you and others talking about scores of prediction of risk of cardiovascular disease in rheumatoid arthritis, and they show many controversies in prediction, and some say that there is no proof that specific scores of rheumatic arthritis would be better than the general score of cardiovascular disease. I'd like to know what you think. There are so many scores like you have just shown, and which one would you prefer to use in rheumatic patients with RA for prediction of risk of rheumatoid arthritis?
Sure. So you're right, Roberto. It's a controversial area. There are a lot of different papers written on this. I would argue that our score, the ERS-RA, has been most carefully studied, developed, validated, and now externally validated. And so while there are lots of scores out there. Every time someone sends me a paper to review, I just ask them to use, there's something called the tripod position paper, which was published in the Annals of Internal Medicine 5 years ago, which is a group of biostatisticians that basically set out a method for developing and validating risk scores. And we followed that very carefully. And I would suggest that people should follow the tripod risk score. And if they haven't, it's a set of methods. And I can tell you that I don't know that I'm aware that anybody else has kind of been very careful with their methodology. So I'm not saying that ours is the final risk score that you must use, but at this point, I think it's been best. The methodology that we used was most closely adherent to what was suggested by this group of biostatisticians for deriving, developing, validating, and then externally validating the risk score. So I would use the ERSRA. I'm happy to share with you information about that. You can find all the information at our website. I think our papers have described it pretty well, and it works pretty well. But I can tell you that it's controversial. So there's people who write me letters that are kind of like hate mail that say that we did it all wrong. And I'm not sure. I think it's because it's a little bit of a competitive area that everybody wants to develop and publicize their own risk score, Roberto. So, you know, I'm not sure why it's so controversial. Really, it just seems like it's a set of methods that everybody should adhere to. But you're right, there are other papers that use different risk scores. There's the EULAR says you should just use something called score and then multiply it by 1.5. But I would ask you to go find the validation of that. It's just an eminence-based risk score. It was a bunch of experts said you should do this. It seems to make sense, and it really has not been rigorously tested. And then there's another group called Attack RA that is a global consortium, and they don't like my risk score for lots of reasons. The most recent one they sent me a letter was that cardiovascular disease doesn't seem to be a problem in RA, and so why should we use a different risk score than the general population? And I said, you know, most studies show a 50% increased risk. So I think it's a controversial area because it's competitive, but again, I don't claim that ours is the final risk score. It's just we wrote it, we validated it, and now others should try it, test it, you know, make it better. I'm happy for others to make it better, and I'm happy to work, you know, to collaborate, validating it in Brazilian data or making it better in Brazilian data. That would be fine.
Thank you very much.
Yeah.
Miriam has another question. Miriam is a dentist, periodontist, and she's exploring periodontal diseases and rheumatic.
Oh, great. Yeah.
Miriam,
So,
go ahead.
yes, according to my background and my expertise, can you explain the relationship between the oral microbiome and periodontal disease and CVD and rheumatic diseases? All these together.
Yeah, so again, I think it's this, there's strong associations between periodontal disease and RA. And that's been shown in many studies. And I think that people don't know exactly whether it's causal or whether it's casual. And let me tell you some of the reasons why it could be one or it could be the other. It could be that it's causal because, like I suggested with COVID, that having chronic gum inflammation becomes a auto-inflammatory disease that then brings on, it reveals certain epitopes, certain proteins that become autoimmune targets. And people have shown that seems to be a progression of that. And we think that in the lung, that we know that in the lung, there's a microbiome in the lung, like there is in the mouth, like there is in the gut. And people think that there's an uncovering of these citrulline proteins that then provokes anti-citrulline antibodies that are what, you know, that we look for in RA. The anti-CCP antibodies are like our new rheumatoid factor. That's what we look for in clinic. So it may be that there's similar uncovering of epitopes, developing of autoantibodies based on chronic periodontal disease. However, it's also possible that people who have periodontal disease are different from people who don't have periodontal disease in other ways, meaning they have different genetics, they have different socioeconomic status, they have different diets, they have different, there's so many other factors that you know better than I do that are associated with periodontal disease. They smoke more. Smoking is a big risk factor for RA. So to parse out whether it's periodontal disease causing RA or periodontal disease associated with all these other factors is really tricky. And that's what, you know, that's what, so, you know, what would be one way of trying to parse that out, Miriam, is doing a study where you cure people of periodontal disease. And then you watch them and you see whether they develop RA or their RA gets better. And people have talked about that. And I have a colleague who has developed a RA risk score, which has genetics, periodontal disease, tobacco use, and obesity. And I said, well, that's interesting, but don't you, if you have a risk score, it makes it sound as if you can cure one part of it, that you would reduce the risk of RA, meaning like if you can cure the periodontal disease, and I said to her, you should just do a big study of curing periodontal disease. So I think that there's different ways of trying, you know, there's epidemiologic methods, and then there's clinical trial methods for trying to get closer to causation.
Okay, thank you.
Thank you so much.
Thank you very much.
Yeah. Bruno, amazing meeting. Thank you. Thank you. Okay. I would like to, we cannot forget about our pandemic times and hydroxychloroquine and tocilizumab and so on. I would like to hear from you about this so controversial topic. If you have time to share your viewpoint about this topic in terms of our drugs, immunobiological drugs and hydroxychloroquine drug, and the cardiovascular risk in COVID-19 treatment. And what do you think about the evidences and how evidence has been developing? What's your point of view? Because our reality here is very similar to yours in terms of hydroxychloroquine discussion. So I would like to hear from you.
Sure. Sure. So I could kind of take that question at multiple levels. On the one hand, I could tell you what we do, and on the other hand, I could tell you how we think about it. On the one hand, what we do is no one gets hydroxychloroquine as a COVID prevention or treatment. No one believes that hydroxychloroquine has any benefit with respect to COVID. And there's many studies at this point that the randomized trials don't show any benefit. And people, so no one's using hydroxychloroquine with respect to COVID at this point. IL-6, the randomized trials have all been negative. So I don't think that anyone's using IL-6 blockers for COVID. we're still waiting on the randomized trials for anakinra, IL-1 blockade, and we're waiting on the randomized trials for JAK inhibitors. So people are still holding their breath, hopeful that one of those might be helpful. But I'm not that hopeful. I can tell you that, that there's lots of case series and there's small, reasonably well-designed studies that look like IL-1 might be helpful, but I don't think we know yet. I think that there's 20 randomized trials going on for anakinra in COVID. I looked this up yesterday, and none of them, they're all recruiting, and maybe some of them will report out in the next couple of months. But until we have a randomized trial, it's anyone's guess whether it works. We don't use it. The IL-6 experience has taught us that you should be very, very cautious about using these unproven anti-cytokine therapies. Dexamethasone is, remdesivir and dexamethasone and prone ventilation are the best things we know for treatments at this point. The next line of treatments are going to be targeted antibodies. Our president got targeted antibodies, from Regeneron. Regeneron has trial. The trials are not reported out, but there's some preliminary data that suggests that these targeted antibodies, they're monoclonal antibodies that are being generated against the spike protein that are neutralizing, and they seem to be useful. And I think that that's going to be the next wave of therapeutics, but it's possible that the anti-cytokine therapies will work, but it's too early to tell. We're not using the IL-6 and IL-1 therapies widely in our ICUs because no one is sure that they work. And so we're worried that we're causing more harm than good. There's kind of a broader conversation about how we develop therapies in the setting of a pandemic, which is an interesting conversation. And I think, that's a longer conversation, more of a philosophical conversation than a, what do I do today when I'm seeing these patients? So hopefully that was helpful.
So let me see. I think we don't have any other, we can discuss a lot. We have a lot of questions, but it could be another time of conversation. And I'm very happy that you are here with us, and also happy to hear that you are available to discuss with us about our study with Roberto and other medium. And also we have several explorations in upcoming days and weeks that we are studying, and it will be very nice to continue talking with you. And so far, I think we can close our meeting. And Heitor, do you have any other comment would like to talk?
No, thank you very much. So I think it's time to finish.
Okay.
Thank you very much.
Thanks everybody for your attention. I'm happy to continue the conversation at some other point, but
okay,
good luck in Brazil. Okay, take care. Nice here, Helen. Thank you.
Bye bye. Thank you.
Bye-bye.
Bye-bye.